Ladies and gentlemen, I was asked to give you a perspective on PVI and left atrial appendage occlusion as a combined procedure. And I have three statements. I think adding occlusion to a left atrial catheter ablation makes sense for many patients. I have selected a quick case for you. It's a 60-year-old diabetic female, hypertension, coronary artery disease, persistent AF, and she undergoes catheter ablation. She has 5 CHED-VESC points or 3 CHEDS points, and now there is a real dilemma for those patients. When this lady would have no more AF in her remaining lifetime, it is guideline recommended to keep her on anticoagulation irrespective what the rhythm shows. And this is a huge dilemma for many ablated patients. They feel nothing, they have clean Holter ECGs, but they have to take the pills and they stay on the risk. And is this risk substantial for future bleeding? This is RELY trial, 3 to 6 CHEDS points. So if you take the recommended dosage, you would be around, let's say, 4% per year bleeding risk, and this is cumulative. And when she goes until 82 years, 100 of our patients, 64 of those, would experience a significant bleeding event when she is out of atrial fibrillation, no AF, but ongoing on anticoagulation. And we have seen this figure already. The occluder has the potential at least to cut the bleeding risk down to 50%. I think this is really in a combination which is clinically supported. And I show you a few slides. Is this approach feasible and safe? And there is limited data which is supporting this. And Fabien, well, you are with your sheath in the left atrium, we are really there. This is the left atrium, and we touch it in any millimeter, and we have a few catheters there. And what I learned from Boris today, well, this is what we do in the left atrium for a few hours. We ablate and we modify substrate, and we have already large sheaths in the left atrium. So when we can use our balloon sheaths, we even would not need to exchange a sheath. We could even use the same sheath. So I think to combine this procedure is really evident. What is the data available? This is very limited. There are few cohorts described. One of the first from Lukas Borsma's group, 30 patients, just a few quick information. It added, and you refine this figure later, between 30 and 45 minutes to put the occluder in with everything what belongs to the occluder. They had no significant complication during implantation, just a prolongation around 30 to 40 minutes. And at the end of 1 year, the majority of patients could terminate Coumadin and were free from anticoagulation. And the data, and this is an overview, so far published, smaller cohorts about combined procedures, they have all the same melody. The procedure time is reasonable, the success rate is very high, and the 1 year anticoagulation freedom is between 70 and 90%, and the AT burden is between 60, 70, 75%. So at least 2/3 of patients have no more atrial fibrillation, 70%, and would keep on going lifelong to take the risk of ongoing anticoagulation. This is the latest trial I found about concomitant cryoballoon ablation. Again, same information. They had a mixture of devices. You see the LAA closure fluoroscopy, 9 minutes. The LAA closure time, 44 minutes in addition to the cryoballoon time, and there were no relevant complications. There is no signal that we add a significant complication rate to our patients, and during follow-up, again, no embolization, no stroke in this cohort. And this is the latest data set I show you. It is the longest experience I found. It's a 5-year follow-up of a combined catheter ablation for AF and Watchman occlusion. There were 98 patients. They had complete success. They had groin hematoma, no other complication in the acute setting. All patients stopped anticoagulation. 77% were free from atrial fibrillation, and there was, during a 5-year follow-up, 1 ischemic stroke, at day 802 post-procedure. So I think this is still limited data, but it starts to convince us. And there's one patient who died from a suicide 5 months post-ablation and LAA implant. You see endothelialization, this patient, and here a small, well, this typical small 1-2 millimeter gap, which is, as far as we know now, not of clinical relevance for the outcome of this patient. A last point for this second session is the personal preference is more and more important, and I think the combined procedure, especially for AF patients, that will fulfill one of the most important hopes that when they have no more AF, they can stop anticoagulation. And this would be possible if you combine the procedure. Let me come to the last point, quick point, which is the most important obstacle for rollout, for really executing that approach. And I'll show you the German figures, and now we talk about money. For a pulmonary vein isolation, you get currently in Bavaria 8,756 euro, and you spend, this is a mean value, around this amount of euro for the material on table you use for the ablation site. The rest is, there's some profit, there is personal, physician's hour, intensive unit care, whatever. So this is consuming this sum of money you get as a DRG. We pay for an amulet device 4,700 euro, and when you add this, you would only spend pure for material, nothing else for 2 or 3 days in a hospital or 2 days. You spend the whole money you get for material. Your controller will you stop next day when you start doing it, and that's the reality. You can do single cases, but you cannot do it now on a regular basis. What is the potential? And this is my last slide. This is the white book from the European Heart Rhythm Association, and I took the German data. You see there is AF ablation 2013, 2014, there was a better documentation, 40,000 in around, now we are in around 160 centers for 2017. This is what we expect in Germany 70,000 AF ablations, and if you go to the databases, 2/3 of those ablations have a CHETS-VESC score of 2 or more. That means they had to be kept on anticoagulation, even in a sexual catheter ablation. So the potential is around 40,000 cases. If you would take it as a whole group, there are patients who can take anticoagulation, but this is the potential for this combination. Thank you for your attention.